Welcome to this educational presentation from Professor Mohammadi's Teaching Archives. Today we will discuss the appropriate use of neuroimaging in children with a focus on common pitfalls and practical ways to avoid them. Neuroimaging can be extremely helpful in diagnosis and management, but only when it is used thoughtfully. The key message is that imaging should not be requested simply to reduce uncertainty or provide reassurance. It should answer a clear clinical question, guide management, and be interpreted in the full context of the child's history, examination, and developmental stage. Throughout this presentation, we will move through the most important sources of error and highlight practical strategies for safer, clearer, and more clinically meaningful imaging decisions. Next slide, please. A structured approach to neuroimaging begins before the scan is ordered. The first step is to define the clinical question clearly. We should ask, what are we trying to confirm, exclude, or clarify? And how will the result change management? The next step is choosing the right modality. MRI is often preferred for the brain and spine when clinically appropriate, while CT remains important in selected emergencies where speed is essential. However, radiation exposure should always be considered carefully in children. Once imaging is selected, the quality of acquisition matters. Motion, poor positioning, and inappropriate protocols can reduce diagnostic value. Preparation of the child and family, safe immobilization when needed, and careful planning of sedation are all important. Finally, interpretation and communication are essential. Imaging findings must be integrated with the clinical picture, and reports should clearly identify urgent findings, uncertainty, and practical recommendations. The golden principle is simple. The best image is the one that answers the right question, in the right child, at the right time. Next slide, please. One common pitfall is ordering imaging without a clear clinical question. In practice, this often happens when scans are requested just to be sure. The problem is that imaging without a specific purpose may reveal incidental or irrelevant findings. These findings may not explain the child's symptoms, but they can create anxiety, trigger unnecessary follow-up, increase cost, and sometimes lead to further investigations that do not benefit the child. To avoid this, every imaging request should be linked to a specific clinical question. The clinician should know what decision the scan is expected to support. Will the result change treatment, urgency, referral, or follow-up? The key practical tip is to document the clinical question clearly in the imaging request and follow evidence-based guidelines. The goal is not simply to obtain an image. The goal is to answer a decision-changing question. Next slide, please. Another important pitfall is choosing an inappropriate imaging modality. Using the wrong test, such as requesting CT when MRI would be more informative, can lead to missed pathology or avoidable radiation exposure. The best imaging test depends on the clinical question, urgency, safety, availability, and diagnostic yield. MRI is generally preferred for many brain and spine indications because it provides excellent soft tissue detail without ionizing radiation. CT, however, may be appropriate in urgent situations, such as suspected acute hemorrhage, trauma, or when rapid imaging is essential. The key is not to choose the fastest test automatically, but to choose the test that best answers the question with acceptable risk. In children, minimizing unnecessary radiation is especially important, so the practical approach is to match the modality to the clinical problem, balancing sensitivity, specificity, urgency, access, and safety. Next slide, please. Poor quality imaging is another major source of error. Motion, poor positioning, or an unsuitable protocol can make a study difficult or impossible to interpret. This can lead to false negative results, repeat scans, delayed diagnosis, and sometimes additional sedation or radiation exposure. A technically poor study may create false reassurance, or it may require the child and family to go through the entire process again. Avoiding this pitfall requires preparation. The child and family should understand what will happen during the study. Age-appropriate protocols should be used, and immobilization should be safe and respectful. Sedation should be used only when necessary, and when used, it must be planned carefully with appropriate monitoring. In pediatric neuroimaging, image quality is not just a technical issue, it is a patient safety issue. Next slide, please. A frequent challenge in pediatric neuroimaging is misinterpreting normal developmental variants as pathology. Children are not simply small adults. Brain anatomy, myelination, spaces, and developmental appearances change with age. If normal age-related findings are mistaken for disease, this can lead to misdiagnosis, unnecessary treatment, parental distress, and additional investigations. This is particularly important in infants and young children, where developmental changes can be striking. To avoid this pitfall, clinicians and radiologists must be familiar with pediatric anatomy and normal age-related imaging patterns. Imaging findings should always be correlated with the child's symptoms, examination, developmental history, and clinical trajectory. When uncertainty remains, using pediatric reference standards and seeking a second opinion from a pediatric neuroradiologist can prevent harm. Next slide, please. Another major pitfall is failing to correlate imaging findings with the clinical picture. A scan is only one part of the diagnostic process. Relying on the image alone can lead to conclusions that do not fit the child's history or examination. For example, an imaging abnormality may be incidental and unrelated to the presenting problem. Conversely, a normal scan does not always exclude clinically important disease. The meaning of an imaging finding depends on the child's symptoms, neurological examination, developmental stage, laboratory data when relevant, and the evolution of the condition over time. The safest approach is to interpret imaging as part of a broader clinical assessment. Discussion between the radiologist, neurologist, pediatrician, and other members of the clinical team can greatly improve interpretation and management. The image must serve the patient. It should never replace clinical reasoning. Next slide, please. Incidental findings can also be missed, especially when attention is focused only on the suspected diagnosis or the main region of interest. This creates a risk of tunnel vision. Important pathology outside the immediate clinical target may go unrecognized. Even if a finding is not related to the presenting complaint, it may still require follow-up, clinical correlation, or communication with the treating team. To avoid this, the entire study should be reviewed systematically. A structured approach helps ensure that no region is ignored. Incidental findings should be documented, and their clinical significance should be communicated clearly. The key is balance. Not every incidental finding requires aggressive action, but clinically meaningful findings should not be overlooked or dismissed. Next slide, please. Poor communication of imaging results is another preventable source of harm. Even when the scan is technically good and correctly interpreted, unclear or delayed reporting can undermine patient care. A report that is vague, incomplete, or difficult to understand may lead to misunderstanding, delayed treatment, duplicated work, or loss of trust. This is especially important when findings are urgent or require immediate action. Reports should be clear, structured, and clinically useful. They should identify the key findings, explain their relevance, describe the level of urgency, and provide practical recommendations when appropriate. Critical findings must be communicated promptly to the right person. Communication is not separate from diagnosis. It is part of the diagnostic process. Next slide, please. To conclude, wise pediatric neuroimaging depends on several core principles. First, start with the right clinical question and request imaging only when the answer matters clinically. Second, minimize harm by balancing diagnostic yield against radiation, sedation, cost, and burden for the child and family. Third, keep the process child-centered. Prepare the child and family, use age-appropriate protocols, and tailor the approach to the child's clinical condition. Fourth, correlate imaging with the full clinical context, including history, examination, development, and disease trajectory. Fifth, interpret carefully. Recognize normal developmental variants and seek pediatric neuroradiology input when uncertainty remains. Finally, communicate clearly. Use structured reports and escalate critical findings promptly. Neuroimaging is most powerful when it is clinically targeted, technically reliable, developmentally informed, and clearly communicated. Next slide, please. Thank you for watching. I hope this presentation helps reinforce a thoughtful, child-centered approach to neuroimaging, one that uses the right test for the right reason, interprets findings carefully, and supports safer clinical decisions for children and families.